I'm going to hand over to Mr. Rajesh Bhushan, Secretary Designate, Ministry of Health and Family Welfare, who's going to chair the next session. And he's going to call upon Ajay Shah and, of course, for the paper, and then for the discussants thereafter. Rajesh, we are giving 30 minutes to our authors, and then we're giving 10 to 12 minutes, I believe, for our discussants, and then floor discussion. So I'm going to hand over to Rajesh Bhushan, please. Rajesh. The volume is a little low. If you can either get closer to the microphone, or that may be a little better, please.
Is that better now?
Yes, I think that's yes. And just make sure we stay close to the microphone, otherwise we may lose you. Please, Rajesh.
Okay, thank you. And the session that we would now be initiating is on Indian health policy in the light of COVID-19, the puzzle of state capacity and institutional design. I call upon Ajay Shah to make his presentation.
I'm afraid, ladies and gentlemen, his phone is also off, so we are not in a good position. I'm sure his connection was tested, and
Shekhar, if I may suggest, so since the discussants have read the papers, this happens sometimes at the NDR, when the discussant actually takes a little bit more time and outlines the key argument in the paper and then also responds. I think that may be our best bet at this point till Ajay comes back.
I think that's a great idea. And given that KP Krishnan has actually either prepared a course or taught a course based on some of the ideas that Ajay and Vijay Kelkar put forward in their book, and I know that they have picked from those ideas in this paper as well. So could I request KP Krishnan to join, and I'm going to request Ajay to log off and log on again into Zoom, and hopefully that will improve the quality of at least his sound. But Krishnan, are you here? And I did see you here, of course. So KP, could you start and maybe start with your comments? And I see Randeep is also here, Dr. Randeep Guleria. So both, I'm sure, are primed and ready. So KP, would you like to lead off?
Shekhar, good evening. I can.
Oops. I think this paper is jinxed. KP, we're having the same problems with you. KP, turn off your video for one thing. KP, turn off your video, please.
He turned off his audio.
Yeah. No. Okay. Go ahead now. KP, try now.
Better?
Yes. Thank you.
Better?
Yes. Thank you.
So can we at least get somebody to show the slides that Ajay has made, because they are quite self-explanatory. So I think it will not be entirely fair to sort of discuss the paper without even a flavor of the paper.
All right. So it's a great idea. Iman, Rahman, show the slides, and Krishnan, just lead, since you know the slides well. Please lead Iman through the slides. Iman, your slides are coming up. Please. There we go. Lovely.
Yeah, move on. So I'm not going to read out.
No, just call out, let people read it themselves, and then, I know you read fast, so slow down a little and then call out the next one.
So essentially, the first part of the paper talks about the distinction between public health and curative health, something we've all known, and looking at the public health side of the Indian health system. Move on to the next slide. Linking public health with something we've known, fundamental sort of basic principles of public economics, that a lot of public health is public goods.
Hello. Hello. Does this work?
Hi, Ajay.
Hi, here I am. Does this work?
Yes, it does. We can hear you. And go ahead, please. I think you called in or something, but go ahead, Ajay.
Okay.
We are on the slide called Jargon.
Go ahead, Ajay.
Okay, thanks. I just want to start by introducing some jargon. This is a very interesting distinction between public health and healthcare. From a public economics point of view, there is a nice, neat vertical split that public health is about public goods and externalities, and healthcare has some amount of asymmetric information and in some situations, market power. It's also useful to think that public health is mostly about prevention and not about cure. So in the India and COVID-19 story, there are really 6 things we should think about in public health. They are contact tracing, social distancing, testing, the statistical system, medical research, and the vaccine. So let's go talk about each of these 6 things. Could you go to the next slide? Okay, let's start at contact tracing. Contact tracing is a very large scale activity. There are estimates in the paper that you could require a peak workforce of something like 300,000 people in the country doing contact tracing. This kind of management problem in public administration has not really been dealt with on a large scale in India. It's also important to remember that unlike, say, school teachers, the contact tracing workforce is not a static workforce. You don't want to hold these employees for the long run. You want the flexibility of having some core civil servants who will be there in the long run, but to be able to dynamically respond to an epidemic as and when it comes along. So in some ways, contact tracing is not a difficult problem in public administration. There is low discretion, the stakes are low, the opacity is low, but there are a lot of transactions and there is this dynamic nature of the workforce. It appears that in India, there is significant capability in contact tracing in some places like Kerala and Tamil Nadu. It was useful that Kerala had a dress rehearsal of dealing with a different epidemic reasonably recently. And I think that would have helped them fix up their procedures and so on. But by and large, in most of India, it is pretty difficult to get this state capacity going. There has been a crazy scramble, for example, in Bombay, in putting together this kind of capability. And there does seem to be significant progress in terms of putting this up. In this context where there was low capability in contact tracing in most parts of the country, there was quite a lot of attraction on the part of some people that maybe you could build an app and maybe an app could really take over a lot of the heavy lifting of contact tracing. I think by now it is pretty clear that there is no running away from the difficult public administration work of building a large complex organization. And in that, maybe an app can do a little bit, but frankly, it cannot do a whole lot. It can maybe do a very little, or maybe it is really not the essence of the problem. Can we go to the next slide? Okay, the next question is about social distancing and the use of state power, of state coercion in social distancing. As economists, for us, we would always stand up and say that you need to think more about the extent to which people will voluntarily change their behavior. We should not think that people are clueless and will not respond to the threat and will not respond to communication strategies. So there is a lot of role for information, for obtaining facts about the level of threat of going down to a restaurant, of going down to walk in a market, and of communication campaigns surrounding that information. And then maybe there is a little bit of a role for state coercion in also forcibly shutting down some activities occasionally. So there's this complex trade-off between the risk of hitting an infection and the economic costs of using state power to coerce people and not undertake certain activities. These trade-offs will differ considerably by location. So we have only one good data set in this, which has not yet been released. This is the data set that was created by sampling in 70 districts by the ICMR in late April. and that research report or the paper has not yet come out. But there are some newspaper stories, and the quick headline finding is that there are some places like the containment zones of Bombay and Delhi where the antibody testing shows something like 30% of the population was positive by end April. And there are other districts in India where the values are frankly zero. So there is very high heterogeneity all across India about the actual threat of getting the disease by walking around in a market, in a restaurant. And you need very high local control, you need local thinking. Also the trade-offs that in different regions, the damage caused to livelihoods by different kinds of restrictions will vary. So this is something where there is a role for a highly decentralized approach. Could you go to the next slide? Could you go to the next slide? Yeah. The next problem we need to think about is testing. A significant amount of the testing capacity in India is in the private sector. And if we want a large surge in testing capacity, there is better management capability to rapidly mobilize humans, labor, and equipment and obtain a large surge in testing capacity. This would also be in the private sector. Now, this is not to say that the private testing industry works perfectly. There is market failure in the private testing industry in the form of asymmetric information. How do you know that the lab is actually testing correctly? How do you know that the lab is not just lying? How do you know that the lab is actually truthfully, honestly doing a good job of the testing? So when this COVID-19 problem came up, we had a weak pre-existing situation that we had not developed the regulatory capacity to deal with the problem of how to obtain ways of addressing this market failure. Now, with reasonably short notice, ICMR was placed into a regulatory role of trying to think about how to address this market failure in the private testing industry. And that's actually a difficult place to be because regulation is a very difficult thing. It takes 10 years, 20 years to develop state capacity for regulation. And ICMR has faced many difficulties in trying to discharge these functions. Another line of attack through which there could have been a way to make progress on addressing this market failure is through public procurement. When the government buys testing from private labs on a large scale, for example, for a voucher system, then the government could put in covenants into these contracts, which could help overcome the market failure. But this was the problem which was faced, that the public system has really scaled up testing quite dramatically. They have worked wonders. They have moved on a giant scale. But we could have got 2x the response, or maybe 3x the response, or 4x the response if we had also harnessed the private sector. And this remains a puzzle to be dealt with in coming months. Could you go to the next slide? The next question we need to think about is the statistical system. As I talked in the context of the social distancing regulation, a really big thing that is needed is that we need to build and release fine-grained data. We need data at every pin code of India about what is the true state of infection, what is the true state of antibodies. Everybody talks about more testing, but actually it's quite difficult to use data from testing and translate that into data that is useful for public health objectives. So let me talk briefly about the kind of difficulties that are faced in utilizing the data. For example, the data that Prachi was using a moment ago. This is data that is coming out of a clinical context where a person goes to a doctor and says that I have a new dry cough. And the doctor might choose to prescribe a PCR test for COVID-19. Now here the problems are that the clinical protocols that are used in deciding whether or not to prescribe a test have changed over time. The rollout of these clinical protocols all over India is heterogeneous. There have been situations where private doctors were prohibited from prescribing a COVID-19 test. Then there were bottlenecks in testing capacity. So when you put these three problems together, A, that the clinical protocols have changed from time to time, B, that the rollout of a changed clinical protocol all over India is non-standard. And C, that there are bottlenecks in testing capacity. What these three problems imply is that it's very difficult to interpret the data that has come out as a side effect of the testing that takes place in clinical contexts. For this reason, this data is really not useful in an economist sense of the word. What an economist would really want, and what the citizen of a suburb of India would really want, is data that is based on statistical sampling. We need a random sample of each neighborhood of India every week, using which we are reporting the percentage of people who are infected and the percentage of people who are displaying decent titers in antibody testing. And this is a very difficult thing to do. As of now in India, in my knowledge, there are really only two data sets in the game. One is this end April study that was done in ICMR, where the paper has not yet come out. And the other is a paper that was done by Anup Malani and some co-authors on a random sample of the migrants who had returned to Bihar. Apart from this, there is really no data available today about the extent of infection and the extent of antibodies. Okay, if you don't observe the infection rate, if you don't observe antibodies, what else can you do? It would be really great if we could observe excess deaths in a more effective way. Now, this takes you back to long-standing foundational statistical systems infrastructure. What you need is a data point coming out in Bombay every single day for the number of people who died in Bombay. No, I'm not talking about even causes of death. You just want one number. Can we have a good statistical system that reports the number of deaths in Bombay every day? Ideally, the number of deaths in Dharavi every single day. That kind of statistical information can be really informative. It can be really valuable. But this kind of data infrastructure is not there in most parts of the country. And this takes you back to long-standing problems of how can we build the public health systems that will be able to cope better with these kinds of situations in the future. Could we go to the next slide? Okay, next we come to the problem of medical research. Knowledge is the ultimate global public good, and in India, we are great beneficiaries of the data and the research that is being produced by researchers all over the world. But there are many India-specific questions that others will not pursue. There are questions about what happens under the Indian heat. There are questions about the large-scale chronic tuberculosis that is present in India. India is unique in the magnitude of the tuberculosis problem as compared to almost any other country in the world. So we need to be doing research about how tuberculosis interacts with COVID-19. There are many, many questions which are enumerated to some extent in the paper. Here, we run into foundational difficulties of the organization of research in India. In most countries in the world, we have mechanisms by which private firms, private universities, private research organizations, and some government research organizations get public funding through a research grant system and a research review system. And this takes you to deeper questions of innovation policy. In India, mostly what we have is a government establishment that hires full-time researchers and asks them to do research. And that is a more inflexible environment, which is not able to rapidly shift priorities and respond to changing research needs. Could you go to the next slide? Okay, next we come to the question of the vaccines. It is likely that decent vaccines will come. There are hundreds of interesting vaccine research projects taking place all over the world. And it is likely that a couple of good vaccines will come probably as soon as November or December. It is important for us in the Indian health policy research community to ask the question, what are we going to do when that happens? What are we going to do when some team in China or some team in the UK or some team in Germany is going to find a vaccine? There's going to be a whole bunch of questions. How are we going to achieve IP? How are we going to access that vaccine? If some lab in China builds a good vaccine, what are we going to do? Then how are we going to solve the manufacturing problem? How are we going to do large-scale purchasing? Who's going to pay for the vaccine? How are we going to roll it out on a population scale? Frankly, we struggle on doing standard immunizations in India. So why will the COVID-19 vaccine be more feasible in terms of rollout? What if it requires 2 shots? What if it requires 3 shots? What if there are budget constraints? What if there are only 100 million doses of the vaccine available? How are we going to prioritize them? So in the paper, there's a bunch of questions that are posed, and right now, all I need to say is that this is a very important question for health policy in India, and it is time for all of us to mobilize around this question and start trying to put down some thoughts and some discussions around how we could do this better. Could you go to the next slide? So drawing on these questions, can we think more about larger challenges of Indian public health? And in the paper, there are some 6 ideas about what we should be thinking differently. The first is we really need to go back to the constitutional scheme where the bulk of public health is a decentralized story. It should be done at the state level. It should be done at the city level. It should be done at the Dharavi level. We should think carefully about what are the public goods at the union government level. And it seems that the bulk of public health is frankly a state subject, is a city subject. And we need to reorganize a lot of our public health to go towards a more decentralized approach. The second puzzle is how should we think of practical public administration problems about contact tracing? What laws will we use? What process manuals will we use? How will we achieve accountability? How will we create measurement systems to track the functioning of contact tracing? How will we create the public administration and the HR frameworks so that there's a skeletal staff in a place like Bombay, which is able to go up by 10x and 20x when there is an epidemic? So we need to get down to those very gritty business of writing laws, writing process manuals, creating accountability frameworks for contact tracing. Next, we come to the market failure in testing and purchasing. How can we build the regulatory capacity through which a large, active, private diagnostic industry can work in a more efficient way where we are addressing that market failure, partly through private initiatives, partly through a light layer of government regulation, partly through the governance of purchasing by the government. And through that, we could get much larger testing capacity, and also we could harness the management capacity of the private sector to triple and quadruple and go up testing capacity quite dramatically. The fourth puzzle we need to think about is the organization of research. At present, we do research by hiring a scientist inside government. We need to think far more carefully about how to use government as a funding mechanism and create competitive frameworks where there are grant mechanisms that go out to private firms, to private universities, frankly, to researchers outside India, and we get bang for the buck rapidly. The fifth challenge we have to go after is the statistical system in health. How can we create random samples at every neighborhood in India? And how can we improve foundational measurement, for example, of excess deaths? And in all these 5 areas, there is a lot of knowledge in India today on systematic processes for the construction of state capacity. We need to think systematically about the steps. What is the market failure? What are the alternative interventions we might like to use? What is the lowest cost intervention that imposes the minimum distortion upon society? Where will we use the coercive power of the state? How can we use as little as imaginable of the coercive power of the state? How will we design government agencies that will discharge these functions? What's a reasonable organization diagram of the government agencies that will do this work? What laws will shape and circumscribe the working of these agencies, both in terms of authorizing the use of state violence and in terms of creating checks and balances and limiting the behavior of the civil servants that work in these state agencies? How can we create checks and balances and accountability mechanisms through which these state agencies will become more effective and achieve state capacity? These steps are actually understood to a significant extent in India today. We have a lot of knowledge from other domains on how to go about constructing state capacity, and this kind of knowledge can actually be applied into health policy also. Can we go to the next slide? Now we turn to healthcare. Once you have finished with the problem of prevention, you are at the last barricade, which is healthcare. So we would love to be in a place like Taiwan, where Public health by and large delivered, even though Taiwan has very high linkages with China in terms of the travel of human beings. The number of deaths in Taiwan so far out of COVID-19 has been a sum total of 9. 9 people died in Taiwan. So that shows you what public health can do. Could you go to the next slide? But once we fail on public health, next you come to the problem of healthcare. Okay, we've got people getting sick. What are we going to do? A key insight to think about is that there is a COVID-19 surge, and that surge will come at different dates at different cities. Every city is operating on a different clock. Bombay and Delhi are the furthest along in terms of how the surge is playing out. Again, I have only read newspaper stories about the ICMR study of end April, which is the most important research project in the entire Indian health system on COVID-19. And if I do a little bit of imagining about what is going on, it seems to me that maybe in places like Dharavi in Bombay, we are actually now reaching herd immunity. This is some of the most optimistic news in Indian health, but we don't know this clearly because this data is not yet clearly available. But in other places in India, we're at a very different place in terms of where we are on the surge, and that surge is coming. So we need to think about this in a highly decentralized way. Each city, each district is on a different curve, and we need to think carefully about where the surge will come. Now, by and large, the bulk of the early response was in the government-operated healthcare system. They have worked wonders in terms of scaling up their capacity, but frankly, their capacity is not adequate to cope with the surge. We need to think more about how to augment healthcare capacity so as to fare better in the surge. Now, here again, the bulk of the healthcare capacity is in the private sector. Could you go to the next slide? So we need to think about how will we harness the capacity of the private sector. Unfortunately, at this time, the private sector is facing very big problems. Very mundane things are coming in the way. A lot of the junior staff of private healthcare organizations commutes to the workplace using public transport from locations far away. And if public transport is not working well, then we get a capacity crisis inside private healthcare organizations. We have a problem with healthcare workers. A lot of healthcare workers have been infected. A lot of healthcare workers are scared of being infected. And we are seeing a decline in the staffing of many private healthcare organizations. Private healthcare organizations are also facing financial difficulties. The non-COVID-19 work of private healthcare organizations has gone down dramatically, and they are facing severe cash flow constraints. And the management bandwidth is absorbed with dealing with this financial crisis at a time when, frankly, in the eyes of some social planner, you want the management bandwidth of private healthcare organizations to obsess on how to triple and quadruple their capacity to deal with COVID-19. Could you go to the next slide? So we need to think more about how to protect the healthcare workforce. This requires very high quality rollout of good protocols. These protocols are well understood on an international scale, but they need to go all the way down to the ward boy. It should not be that we cut corners with some parts of our staffing. So there is a gap between the protocols that we see on websites and the protocols that are actually rolled out. Similarly, we need to find ways to protect healthcare workers and their families when they get sick, because if these things are not done, then there is a greater chance of healthcare workers being uncomfortable and choosing to not come to work. And we need to think of ways to address the transportation constraints in places where public transport is not yet fully working. Could you go to the next slide? Next, we come to the problem of healthcare financing. All over India, some random sample of India is going to get sick. Most people who get sick do not require significant expenditures, but a small fraction do. And going into an ICU, potentially requiring supportive therapy inside a hospital, potentially requiring oxygen therapy, these things can be pretty expensive. This is a very insurable risk, because a tiny fraction of the population gets sick. Most people don't get sick. We need to think of ways in which we can make insurance work more effectively. There is one large insurance system, which is ESI, where, frankly, the theory of ESI is correct, that you're supposed to be insuring the employees of private firms who have been mandatorily railroaded into becoming customers of ESI and into making contributions into ESI. But in most of India, ESI is not there in the field, having the ability to deliver the healthcare that is kind of promised by ESI. And if ESI could learn to contract with private firms, then we could get a lot done right there. Similarly, there is a lot going on in India in terms of government-funded health insurance schemes. These are present all over India at the state level. For example, in Kerala, there is a system that is called CHIS. These pieces are there all over India. The latest kid on the block is Ayushman Bharat. We need to figure out how to make these programs work better. And it really boils down to one question: how to buy COVID-19 services from private healthcare organizations, how to solve the government procurement problems, how to achieve cost efficiency, how to combat market failure that is present in the behavior of private healthcare organizations. So this is really where the rubber hits the road. This is the battle that needs to be crossed, and we need to put our heads to figuring this out. Could you go to the next slide? So to summarize, the pandemic has been a giant stress test for the Indian health system. This is a very good time for all of us to see the Indian health system in action, to understand the difficulties. These are being starkly visible as we see the story unfold. And then we should be thinking about what are the most useful reforms. And the insights that we draw from COVID-19 diverge considerably from a lot of traditional thinking. If you read economics journals for the last 10 years, you would get very little knowledge that is useful in understanding the health policy problems that we see in India today. In particular, we should think more about public health and not about healthcare. We should recognize the dominant role of private healthcare providers, which are not blameless. There is market failure with private healthcare providers, and we need to think about how lightweight solutions can be obtained for that market failure in a way that is sensitive to the limitations of state capacity in India. We know a lot about market failure and state capacity in the field of public administration and public policy in India, in other fields. And a lot of that knowledge and that toolkit can be usefully brought into the health questions that we face in India today. There is considerable knowledge and experience about what I call the systematic process of public economics and public administration, which runs in 4 steps. Question 1, what's the market failure? What are the lowest cost interventions? Question 2, what's your design of accountable government agencies? And what are the public choice theory constraints that limit the ability of individuals inside those government agencies to work for the interests of the people? Question 3, how would we design the laws? What is wrong with the Clinical Establishments Act? What is wrong with the Epidemic Diseases Act? How would we write laws through which we would actually minimally use the coercive power of the state to address market failure while recognizing that there are important constraints from public choice theory? And question 4, how would we design these organizations? How would we write process manuals? How would we enforce these laws effectively? Thank you. I'm at the end of this talk and would love to hear what others think and carry this discussion forward.
Rajesh, over to you.
Thank you, Ajay Shah. I think we are running 7 minutes late, but that would be a test. I would now request KP Krishnan to share his comments on this presentation and the paper.
Thank you, Rajesh. Am I audible, Shekhar? Can I keep the video on?
Yes, you are. If you can just come a little closer to the mic, that will help.
Yeah, I will. And thank you, Shekhar, for this opportunity. And I want to first thank Ajay for this excellent paper and an equally good presentation that he did just now, despite the technical glitches. My experience in government, long as it is, the lesson, one major lesson that I want to sort of start with is that for a number of complex questions of public policy, very often what is required is a good understanding of something as basic as information asymmetry and perhaps the two essential characteristics of public goods, namely non-rivalry and non-excludability. I personally believe, having dealt with a wide variety of subjects, whether it's finance, urban development, land, skills, cooperation, that is the Department of Cooperatives, that these concepts can explain many of the things, far more than what people realize. And I think their non-understanding and their non-application can also explain many egregious mistakes in public policy. So the Kelkar Shah book and a lot of Ajay's presentation today is from that excellent book. I think the book and the presentation today that we saw apply these principles very sensibly. And I think by and large, talking about today's paper, I think draw mostly the right conclusions. Now, I want to use the balance 7-8 minutes as a discussant to talk about one or two issues beyond the paper. Ajay certainly touched upon it, but I want to go a little beyond the paper and relate it to my own experience of what I am observing, both in terms of the COVID activities and the response of the government. The first point I want to make is it's something which comes sort of here and there in Ajay's paper, but I think for future, we need to keep in mind an important part of public goods, which is they have a spatial dimension. And I think this becomes particularly important in a multi-level or a multi-unit government. Now, take India as an example. As per the Constitution, we now have formally 3 levels of government, and we have distribution of responsibilities to those various levels of government. And I think it's important to study, as economists, for us to study these and see whether the public economics principles and the spatial dimension of public goods that we know are actually embedded in the Indian constitutional distribution of responsibilities across governments. Now, a lot of you are familiar, maybe some of you are not entirely familiar. In the Indian Constitution, the 7th schedule deals with union state distribution of subjects. That is both legislative subjects as well as the executive power in the absence of and with legislation between the government of India, formerly called the Union of India, and the state. And the 11th and the 12th schedules, which were added much later, post 1984, deal with the distribution of responsibilities to the local governments, that is, rural panchayats as well as urban municipalities. Let me start with the 7th schedule first. This, I repeat, is the schedule that deals with distribution of legislative and executive responsibilities between the union, central government, and the states. The schedule has, the 7th schedule has 3 lists, one each for the union, one for the states, and a third one, which is somewhat peculiar to India. Not very many countries have this, called the concurrent list, on which both the union and the states have jurisdiction. Now, let's look at the items. Item number 6 of list 2, that is the state list, is public health and sanitation, hospitals and dispensaries. So, prima facie, you would think public health is a state responsibility. However, dig deeper, and the story is very interesting. Item 28 of the union list mentions port quarantine. In the context of shipping, port quarantine is with the union government. More interesting, item 81 of the union list talks about, and very interesting in the present context, both interstate migration and interstate quarantine in the same entry. It's almost like some founding father in the Constitution almost visualized March 2020 and spoke about interstate migration and interstate quarantine in entry 81 of the union list. Equally interesting, there is an item called 29 in
Krishnan, your voice may
which
be...
mentions the following, and I quote
Krishnan,
this verbatim.
sorry. So your voice may be fading. I
Yeah.
think we may want you to turn your video off.
Okay, is it better now?
Yes, much better. Thank you.
Yeah. So the list that I was talking about in the concurrent list, item 29, and I quote this verbatim, prevention of the extension from one state to another of infectious or contagious diseases is item 29 of the concurrent list. Now let me quickly look at the third tier of government or the local level. And as I mentioned earlier, the 11th schedule read with something called Article 243G deals with rural panchayats. And there is an item, an entry called 23 in that schedule, which is health and sanitation, including hospitals, PHCs, that is public health centers, and dispensaries. Then there is a 12th schedule, which is read with 243W of the Constitution, dealing with urban municipalities. And entry 6 in that schedule is public health and sanitation. Now, to summarize this part of my discussion, the subject of public health is allocated to the state governments as well as local governments. That's the first direct conclusion. However, there are many elements of public health, especially relating to contagious diseases and pandemics, which are also in the union and the concurrent list. So you could say either of the following. A, there was confusion and lack of clarity, and you see the subject distributed all across the Constitution. Or you could say that the subject is indeed complex, and there are elements of this broad item called public health, which has national elements, which has state level elements, and elements that are local. Now, having dealt with the constitutional side, let me quickly run you through some provision of the act that has been most extensively used to deal with this pandemic, the Disaster Management Act of 2005, and which has been the sort of the linchpin of the Government of India regulatory action during the, at least the initial response. Now, as per this act, a disaster is defined as a catastrophe, a mishap, a calamity, or a grave occurrence in any area arising from natural or man-made causes or by accident or negligence. But more interestingly, disaster management includes prevention and mitigation, or prevention, mitigation, and reduction of risk of any disaster or its severity of consequences. And the national authority that is constituted under this act has powers, a large number of powers are listed, but including steps for mitigation, prevention, and preparedness. Interestingly, Section 11 of the Act has a mandatory requirement, and I think at some point, this is something which will be looked at by all agencies which are looking at accountability. There is a mandatory requirement of drawing up a national plan for disaster management, including all that I've mentioned above, and a requirement, again mandatory, that it needs to be reviewed and updated periodically. Now, in the light of these constitutional legislative provisions, what are the questions I'd like to pose for future research and for further work? A, based on our experience of fighting and the continuing fight on COVID-19, is fighting a pandemic a national public good, regional public good, local public good? How do we unpack this? Clearly, there are, number two, elements of all three. Migration, flights, etc. need to be dealt with nationally. However, ICU beds oxygen perhaps need to be dealt with at the state level. And the examples that Ajay quoted, Tamil Nadu, Kerala, and subsequently Mumbai, successful contact tracing and enforcing of quarantines was actually best done at the municipal and the local panchayat level. Clearly, that's a local good. So I think we have to break this broad entity called public health into many constituent elements, do more detailed analysis, figure out the nature and characteristic of each of them. And the national authority clearly, I think, had its work cut out on January 20th at least, if not in December, when we had already formally reported cases and which the health ministry was aware of, not large numbers, but the beginnings of what looked like a contagious disease. And I think by the end of the lockdown, clearly we should have got a revised national plan ready. I admit, Monday morning quarterbacking is easy. And in retrospect, we all have, excellent vision. But I think in terms of lessons, not getting this right led to a lot of problems. And I just want to highlight one problem before I conclude. The wrong unit for decision making clearly will lead to a lot of perversities. One perversity that I am personally aware of, a district in India, which happens to be an intermediate district through which a lot of traffic passes, there was an excellent mobile COVID testing facility that was available, ready to be mounted by a very large public charity and offered as a free service. The district magistrate said, my district's count of COVID will go up. I will not allow this. And he actually banned it under the same Disaster Management Act. We've seen districts doing this. We've seen states doing this. So this crazy competition for low numbers at some unit level and jeopardizing what should have been a much more coherent plan clearly is one perverse consequence. I think there are many more, but given the constraint of time, I want to stop here. And I think based on Ajay's paper and a lot of other data that is coming in, perhaps there is a good opportunity for us to do research on a lot of these, I think, serious public economics / public health questions. Thank you, Shekhar, and thank you, Rajesh.
Thank you, KP Krishnan ji. There were certain very specific issues that you raised, which emanate from the union list, the state list, and the concurrent list of the Constitution of India, as well as the National Disaster Management Act. And these are themes and sub-themes that must be developed further and would require a lot of stakeholder consultation, deliberation, and research. Now, I would request Dr. Randeep Guleria for his comments, please.
Thank you very much, Shri Rajesh Bhushan ji. And I'd like to start by really complimenting Shri Ajay Shah for an excellent paper. I think he's done a tremendous degree of research, and it's really up to date in terms of the challenges that we are facing as far as COVID-19 is concerned. I'd like to start with what was the situation pre-COVID, and then see what the health sector had to do when COVID-19 came into India in a big way. If you look at the pre-COVID condition, it was dominated as far as the health sector is concerned by the private sector. Probably 70 to 30 was the ratio, that 70% of healthcare was being provided by the private sector. There was a lot of out-of-pocket expenditure still happening as far as health was concerned. We had a lot of schemes which were mentioned in the paper, including the PMJ, the Ayushman Bharat one, which was really making a difference, but there was still a large section of the middle class which was having a huge problem because of having to pay out of the pocket. And many individuals who went into an ICU really lost all their savings. And we've seen that a lot because we've had to shift patients to our hospital, not because they were not being managed properly, but because the family had just run out of money. And then there was underinvestment as far as the public sector was concerned. And there were issues of quality of care, especially at smaller cities and in the district hospitals. And of course, we were facing an increasing burden of non-communicable diseases. The burden of disease in India has shifted somewhere around 2003 from communicable to non-communicable diseases, and more than 50% now, almost 60% of the burden of disease in India is the NCDs, which includes diabetes, cancers, chronic respiratory diseases, and other diseases which are non-communicable. There was also a huge challenge as far as human resources was concerned. We had this whole issue of shortage of doctors, shortage of health personnel, whether it be cities or whether it be rural India. And a lot of effort was being done to increase the number of colleges, to get private sector hospitals on board to become teaching centers and start what was known as the DNB courses, and also to look at how to get nurses into care in the form of having what we call nurse practitioners. And also the whole concept of should we actually look at family physicians at smaller levels, because that is the concept that was missing in our country, and we had actually gone more towards specialists, but that was not going to work in smaller cities and in district hospitals. So this was the background of what really was happening in India when we had the pandemic hitting us. A lot of challenges suddenly came up as far as India was concerned. It's not that India was not prepared or was not anticipating a pandemic. Way back in 2005 or even early 2000, one has been talking in the government as far as pandemic is concerned. The Joint Monitoring Group was created really to look at outbreak management in the government of India. We had discussions, I remember, in 2003-04 as far as after SARS. And we had another outbreak at that point in time, which was H5N1, which was known as bird flu or avian influenza, which caused a significant amount of death in poultry in Maharashtra, in Bengal, in Northeast. But luckily that virus was not having that capacity which COVID virus has of sustained human-to-human spread, although it had a case fatality of more than 60%. But at that point in time also, there was a huge concern, not only in India, but globally, that there would be a pandemic. And we did have a pandemic in 2009, H1N1. So there were lessons that we had already learned, but still you're never really prepared till it really hits you. And there were some good points that we did manage as far as the pandemic was concerned. There was a lot of proactive involvement of the government. We had very early screening at airports. We had a very aggressive initial lockdown. This gave us time to prepare. We had COVID care centers, the COVID hospitals, the COVID ICUs. Oxygen facilities were actually made available, and ventilators to some extent was also made available. There was also issues that we really handled in terms of testing and in terms of training. But there were a lot of downsides also which we faced as far as the pandemic is concerned. And I think those are the lessons that we need to really look at and what we can do. One, of course, was the decrease in the private sector involvement. I mentioned that the private sector is involved to a large extent when it came to the pre-COVID area, but the involvement when it came to the COVID pandemic was much less, and there had to be a lot of, let's say, strain on the already sort of strained and existing government sector. And therefore, a strategy needs to be developed where we can get more and more private sector involvement when it comes to an outbreak management, because the bulk of ICU care or ventilatory care still lies in the private sector. In a large number of district hospitals or even smaller hospitals, you don't have oxygen supply which is easily available. You don't have a large number of ventilators. Health resources in terms of critical care specialists are a huge challenge. And that became one of the major issues. Contact tracing has already been discussed in the paper very well. And I think that was another challenge that was faced in terms of doing it aggressively. The biggest involvement as far as contact tracing was challenge was the stigma which got associated with COVID-19. I think here the challenge is to be able to really reach out to the public and be able to get them over the stigma. I know many individuals who had classical features of COVID but just refused to get themselves tested. And many of them actually went into respiratory failure and then had to be rushed to the hospital. So because of the stigma, there was, because if you are doing contact tracing, your contacts are picked up once someone starts reporting symptoms. There is no real sign that you can really diagnose COVID. Someone has to report that he's having fever, he's having cough, he's having shortness of breath. And I know that in certain areas of even New Delhi, there were people who just refused to report these symptoms. And this led to an increased spread of the disease in that area, leading to a cluster formation. So I think that is one of the challenges that we faced in terms of people underreporting and increase in the surge of cases. There was a huge challenge as far as testing is concerned. This has been brought out in the paper also, but it's important to understand that when we started, and this is something that we realized way back in 2009 when we were looking at H1N1, there were very few good quality virology labs in the country. And that became a big challenge. As a matter of fact, the initial lab structure was done by support from CDC and by National Institute of Virology, but these were to have a surveillance for influenza. And when you are looking at a virology lab, there is a lot of issues of infection control. You need investment in terms of a BSL-2 facility. And this was something which was not available to a large extent. And during the lockdown, this was really upscale. We got medical colleges to build labs to start testing. And from a time when we had just about 100 to 150 labs, we have now gone over to 1,000 labs. And the number of tests also from 10 to 20,000 have crossed 2 lakhs per day. So that was another challenge that we faced. But here again, the challenge that we are still having is that it's very difficult to get the private colleges to come on board in terms of doing the testing. The investment in setting up a lab in certain private colleges is not happening. And that again is something that we need to look at in terms of some sort of a partnership or some sort of a way that we can do that. The other thing that was mentioned in the paper, which I think is very, very important, is the statistical data. There's a huge issue of data that has to be collected in terms of looking at the antibodies, the number of people who have tested positive, the mortality, or even just hospital data as to look at what are the comorbidities. We really have no idea as to, does malnutrition serve as a risk factor for severe COVID? Does past history of tuberculosis serve as a risk factor? If you have underlying bad lungs, do you get more severe COVID? We have a younger population, but we have a higher number of diabetics. So are the younger people who are diabetic more prone to develop COVID-19? These are research questions, but you need data really to answer many of these research questions. And I think we need to really look at a national database, which could be electronic, which needs to be developed, and which is sustainable even subsequently, because this will also help us as far as surveillance is concerned. But the challenge is who collects the data. If you're going to ask that it's being done by doctors who are already overburdened, it's not going to happen. How do you make sure that the data is done in a proper manner, that the data is fed properly? And this was brought out by even in the paper, that very often states try to hide the data because they want to show that they're doing better than others. So the death reporting becomes less, the number of cases become less because you're asked to test less people. And therefore the credibility of the data is something that we need to look at. And then of course is how do we make it sort of available to everyone? I think when we have a national database, it should be something which is available to all researchers so they can do a deep dive into the data and see how it can really help them to come out with solutions which could help save lives, which could help a better policy management. And I think this is something that we need to really develop in the long term when it comes to not only COVID, but even post-COVID management, as we look at the paradigm shift towards non-communicable diseases, because there also a lot of data is required as far as this is concerned. And I'll conclude by actually just saying that the lessons that we've learned is we need increased investment in health. We need to focus on primary health. We need aggressive surveillance. And also there is a need to have a good public-private partnership in the long run so that the private sector can also come on board as far as healthcare is concerned. There's been a lot of talk that we need to have incremental assurance-based approach so that health becomes a right as far as India is concerned. So thank you very much for the time given to me.
Dr. Guleria, for giving us a insider's perspective of the pandemic and the response to the pandemic and the challenges that the handling of the pandemic so far has highlighted. I think we have time for a few questions. Do we have any questions?
Rajesh, the panelists and others are raising their hand. I see a hand up for Karthik Muralidharan, so why don't we let him go?
Let's hear Karthik as long as he's brief, because we have now 10 minutes. Go.
And with your permission, we may extend that a little bit since we ate into this session with the last session, extending a bit beyond, but that will come to at 9:30.
Yeah, yeah. Let's hear Karthik first.
Um, Excellent. So just wanted to first, I think, thank and congratulate Ajay for an excellent paper. I think, like Jeff and Kaushik were saying in the comments, to most public finance economists, this is kind of, it's bread and butter basic stuff, but it's really useful to go back to first principles in a crisis like this. So I have basically one broad comment and one concrete question / suggestion. So I think the first coming from the previous session on the economy, I think, around the world and in India, unfortunately, a lot of the public discourse, at least in the early years, and sometimes even now, seems to be phrased in terms of lives versus livelihoods and health versus economy. And I think this is one of those areas where almost every serious economist is kind of, I think, unanimous that you have to tackle the health first before you can even think about the economy. And so, basic calculations that I've done, that others have done, Paul Romer has done, I think the public return on investment, going back, connecting this session to the previous session, when we were talking about fiscal deficit and concerns of where will the money come from? I think it's so clear that the public return on investment on the public health investments needed to control COVID will be of an order of magnitude higher than anything else you can do. So I think this is a chance, at least, where all the economists are unified with the health community in terms of asking for larger budget allocations, conditional on paying attention to Ajay's second critical point, right? And this is the key point I wanted to make, and which is that the economists will support the increase in health expenditure if it is very clearly allocated for public health as opposed to curative health. And I think the basic pathology of healthcare expenditure, whether it's in India or even in the US, okay, this is not just India. So, because the curative health is when the need is immediate and you're willing to spend, the willingness to spend on curative health is much, much higher than the preventive public health. And you can see this if you go to Harvard, right? So the Harvard Medical School has some of the most gorgeous buildings and endowed professorships. The Harvard School of Public Health is always incredibly poor and scrounging for money. So this problem exists all the way, whether it's in the US or in India. And I think, one thing that is useful to also reflect on is that, see, the structure of the health system in a way reflects the structure of society more broadly, right? So societies that are highly unequal tend to focus on curative care because curative care is excludable and differentially targeted to the elite. Whereas societies that are a little bit more egalitarian, whether it's Vietnam or whether it's Kerala, tend to then prioritize the public health. And you see the returns to those public health investments today when in a time of a crisis, those systems have the capacity to handle what is needed. So I think, the first overall point is that as a country, we should have a consensus, and I think there'll be strong support from the economist community that we need to augment spending. But the second piece is that on healthcare, and that spending should be allocated preventively. So I think the other concrete question / suggestion, now that we have Rajesh ji, chairing the session, is how do we take the excellent ideas that Ajay has put forward in this paper and just make sure that this is concretely reflected in the day-to-day strategy, both the strategies as well as the public communication of the Ministry of Health, given that, we obviously are in a day-to-day firefighting mode, but you need kind of this long-term strategic view on optimal allocation of public expenditure and, embed that in how the government is approaching, everything from data to public, what is the public good and what do we need? And can we come up with a way, even in this forum, to practically integrate Ajay's ideas and, ideas that many of us have written about and will support into, the conduct of health policy for the country at this time of crisis?
Thank you, Karthik. You're right. As a very quick response to opportunities that present themselves before us for a long-term relook at public health, is the forum of the 15th Finance Commission, which is presently engaged with the union government and its various ministries and would be finalizing its report. So that is one institutional opportunity available. The second opportunity available is the coming monsoon session of the parliament, where the political parties would get an opportunity to engage with this issue, which usually is not part of the mainstream political discourse. So that is another opportunity. Do we have any other suggestions, comments?
We have several hands, Rajesh, but before we go to that, I should just mention that apropos your first suggestion, both N.K. Singh, the chairman of the 15th Finance Commission, and Ashok Lahiri will be chairing the two sessions tomorrow. So we really look forward to their involvement, and we hope that we can actually take this message. And as you assume office, if there are ways in which this forum, the paper, and the discussion we are having can inform your further strategic thinking about how you wish to reshape health policy in India, we'd be delighted to help, both from the forum and obviously from NCAER. I see that Rohini Somanathan had her hand up first, and so maybe we could ask her, and then Pankaj Srivastav and Raghu Kawale. Pankaj from MOSPI and Raghu Kawale from Infosys. Rohini?
I have a couple of questions for Dr. Guleria. Actually, it's very nice to have the opportunity to listen to you. Dr. Guleria, I'm very keen on the specifics of the public-private partnership that you talk about. So what are the most important elements of it? One thing I heard, what happened to us when COVID-19 struck is, as a class and as students and faculty, we just reached out to as many people as we could, and we talked to them on the telephone. And some of these were doctors, some of these were policemen, some were just citizens, migrants. And one of the things that doctors from state hospitals said was that if we just had a way of getting our existing patients, even if you were declaring state hospitals to be COVID hospitals, maybe we could have moved all our private patients, all our other patients to private hospitals. So these are the kinds of things that I think could, if systematized, really help us if something like this struck again. What are the other kinds of institutional changes you think are really important? I've had nothing but respect for AIIMS. It's just a remarkable institution. The doctors are overworked and they still keep going. They're just absolutely amazing. And so I think if we can actually bring this into the policy debate and we have government people around and we could be serious about it, it would be really wonderful if we could have your thoughts on how to do that. That's one. The second thing is, don't you think that if we actually had a data center, I know you say that doctors can't do it, but if we had a data center that was at AIIMS, it is a teaching hospital, there are a lot of AIIMS all over the country. I think it could really help in the teaching. And, like a lot of schools of medicine, it's not as if the doctors would be doing, there would be faculty who would be doing this part-time and clinical things part-time. I've had a lot of medical people in the medical profession who come and they find that clinical skills are excellent here, but people are too overburdened to do research. Don't you think it could also help the hospital if we thought about a data center at AIIMS here and AIIMS in other places also, that could then link up to other tiers and other state institutions? Those are my two questions. Thank you so much.
Rajesh, may I suggest that we take a few questions first and then request our commentators and Ajay Shah to respond, if that's all right with you, Rajesh?
Yes, perfect. Let's take some other questions.
I see two other hands. One is Pankaj Srivastav and then Raghu Kawale.
Hello, sir. This is Pankaj Srivastav. And sir, I have worked in health ministry for 3 years. I am with regional health offices. So I have some amount of understanding about the issue. So talking about this Ajay Shah's paper, sir, the issues which are flagged is definitely, they are very relevant like issues. But the critical factor probably, which we probably are missing at this time, is the novelty factor with this COVID thing. It is a novel COVID coronavirus. So we do not know how it will behave. So the protocols, the handling, the labs, So all those things are to be defined, identified first, then only we can have a mechanism of implementing that, whether it is a data reporting system or something. So that is one quick thing about the challenges which the coronavirus, because it is a novel thing, it causes strain on many things you need to understand. Second, about data systems, sir, this is to Rajesh Bhushan sir as well. We have, we talk about data system, definitely. We have an integrated disease surveillance project, IDSP, which is about the data, capturing data from the district level and the labs and other things. Could not this be ramped up to get the data from the lowest level, and then it is in a, that is my brief question, sir, about the data systems, the IDSP project, sir. Thank you, sir.
Rajesh, Raghu Kavale was next. If you could just take one more question.
Yeah, Raghu, this is Raghu here. Hi. I work for Infosys, and I also teach a subject called digital medicine at Manipal University. That's my passion. And of course, we have the Infosys Foundation. So I have one observation and two questions. The first observation is that we do have this strong suspicion of the private sector. And if you look at what happened to agriculture, as economists, all of you are economists here, I'm not. I run a business. But you tried the input costs by saying that you will regulate his fertilizer cost, his electricity cost, you tied his output costs, and ultimately a lot of agriculturists just moved away. And today I hope with liberalization of agriculture last month, agriculture will again start to boom. Something similar is possibly happening in medicine. So where is the return for the private sector if private sector were to be induced to come into the medical field, and where is the trust? Because when we run the foundation, we have gone to many places to say, okay, here's the money, but then we have found a lot of resistance. So I have two questions. One is, what is the mechanism to make capital more, to capital pay for itself? After all, as economists, you can't just put in capital and say it won't pay for itself. And the second question is on data, which is a different subject. You know, when COVID started, we started off all this data modeling. We had NASCOM, we had CII, we had everybody, we came in with the data model. Then nobody took the data models. And then what happened, ultimately, I converted it into a semester end project for my students. And that's what it turned out to be. Okay. And even now, from the IT industry, we are happy to talk to the government. We have been talking to the government. When we talk about data, there are various models. Obviously, data has to come in for us to use tools, technologies, etc., and data has to be given to us. And there's only one state which sort of took it up and said, they have welcomed me and they asked me to come in and start working on it, which is Kerala, which has said, let's look at all the data. And I had the entire KGU, which is the medical university, come in. Can we look at, I'm speaking for the entire IT industry. Can we sort of look at using that and actually using those models? There is a lot of talent here and we can get that to bear.
Raghu, are you finished?
I think he is, Rajesh. We may turn to the to Ajay and to the commentators.
To Ajay and to Dr. Randeep Guleria, starting from Rohini's questions, and then we can go to what Pankaj observed about the newness of the virus and the IDSP program, and then we can come to Raghu where he talked of private sector and lack of trust. So who would take it? Would Ajay take questions first, or would Dr. Guleria take it? Feel free.
Why don't we have Ajay go? Ajay, go.
Mr. Bhushan, I think you'll have to speak a bit louder. I don't know, it's a problem with your mic or whatever. We missed you in the last 1 minute.
No, that's right. Raghu is so why don't we have Ajay Shah come in? Ajay?
Thank you very much. It was a great discussion. It made me think about a lot of things. And I would like to quickly respond to some of those things, but equally with a sense of trying to carry this conversation forward and do more work in the future. Okay, so KP Krishnan talked about better thinking about the constitutional separation between the work of the union government, the work of the state government, and the work of the local government. This is 100% correct. We need to think more coherently about who has to do what, and it is an important next step in thinking about health policy in India. Then Dr. Guleria talked about many things. I want to take on two things. You said that there is a lot of work which was done in setting up like the National Institutes of Virology and so on. I felt that in the field of testing, PCR machines are fairly generic. The private sector knows how to buy PCR machines. The private sector has the management capacity to rapidly scale up testing capability all over the country. So it did not seem so much like an exotic thing that was difficult to do. It was actually reasonably straightforward. All you needed was a PCR machine, and PCR machines are not difficult to come by. All private labs do have capabilities and the management capacity to enlarge their PCR capabilities. Okay, on databases, what you said, I think is 100% correct. I agree with you. I think the framework we should be thinking of is that private labs should be coerced by the government, or there should be testing vouchers through which there is public funding that is conditional on submission of data, so that there are APIs where private labs are submitting data up to a government facility. And then there is API-based access to researchers. And this fits naturally into the mandate of ICMR. And it seems to me that this kind of project is feasible. By the way, similar things have been designed in the field of finance, and a lot of that knowledge can be brought to apply on health as well. Karthik, you said health versus economy is not a trade-off. I would just gently say that it is possible to conceive of a complete lockdown which gets you to consumption of zero, and U prime of C goes to infinity by the time you get to zero. So I think that there are trade-offs that we should think about, and depending on your opportunities for state capacity in public health, sometimes you might rather like to let the disease roll. I would not rule that out. I would point out that in public health, the money required is frankly low. It's a very nice split that public health is externalities, public goods, and inexpensive. All it requires is state capacity. Healthcare is asymmetric information and gigantic gobs of money. So it really makes so much sense for us as economists to focus on public goods, externalities, that is public health. But frankly, the money required is not the bottleneck. The bottleneck is state capacity. We need to think about what is the appropriate intervention? How can we get bang for the buck? How can we translate public funding into the desired outcomes? Third, I wanted to touch upon what you said about inequality and the rich and public health versus healthcare. Actually, I used to think about this exactly upside down. You could be super rich in Delhi and you're fine in terms of buying your own healthcare. But only if the state will get its act together will you get protection against bad air or against mosquitoes. So in fact, by the time you get super rich, you don't care about anything the government does on healthcare, but you desperately need the government to do public goods and externalities. So in fact, I think about this exactly upside down and would love to debate with you further. Pankaj Srivastav said, but it was a novel coronavirus and it took time for us to understand it before we could mobilize a response. Agree 100%. And so we need to think of the scientific end of the national public goods, of coordinating the acquisition of knowledge from elsewhere in the world, of commissioning, setting out grants for research in India for India-specific questions, such as the question of what would happen in the Indian summer, such as what would happen with tuberculosis, and figuring out what is the most appropriate strategy for both public health and healthcare in India. On data systems, you talked about the integrated disease surveillance project. So I would just say, once again, coming back to the sort of thing that Krishnan was talking about and that Dr. Guleria was talking about, we need to think from first principles of public administration that in a world where the dominant force in testing in India is the private lab, what is the mechanism through which we will build the statistical infrastructure whereby there is data submission by private labs. There's a very limited use of state power and state violence in producing certain data sets. And these data sets are made available for research while being super careful about the privacy of individuals. Raghu Kavale said, regulation is messy, regulation doesn't work well. Don't mess with the ROE of medical care. We need a vast expansion of healthcare in India. We need 10x the capital that is presently in the field, and that can only come from the private sector. I agree 100%. We have to be very cautious. In field after field after field in India, we have gone in with heavy-handed use of state violence in regulation, and it has worked out badly. Regulators have destroyed one industry after another in India. We should be very careful before using state violence in the regulation of healthcare in India also. But we need to recognize that there is market failure. We need to find innovative ways to deal with this market failure. We should really be dreaming of far more private, cooperative, Gaussian solutions through which we get people together to address market failure rather than heavy-handed setting up bureaucracies. That's all from my side. Would love to hear what others have to say.
Would Dr. Guleria or KP Krishnan ji want to respond to some of the questions that were addressed to them? Dr. Guleria?
Okay, I'll start. First of all, I think we had very good questions and discussion. I'll just address some of the questions that were addressed. One was regarding the public-private partnership. And I think there are multiple ways that we can really look at a public-private partnership. It could be hospital care, some sort of a care that was already mentioned, especially at a primary and secondary level, where there can be some degree of involvement of the private sector also in terms of looking at certain areas which the government sector is not able to handle. And sometimes that is also being looked at in terms of the PMJ insurance that is being given to the private sector. The other area that I thought has been useful is because you don't have trained specialists, use telemedicine to really use the private sector and specialists there to really help manage patients. This is something that is being done in COVID also in the form of what we would call eICUs or telehealth, which can be done. And the private sector could come on board and there could be involvement that could be done. The third area that I think the private sector can play a role is as far as training or teaching is concerned. There are a huge number of beds which are present in the private sector, but they're not really used for training. They're just used for patient care. But if we start utilizing the services of these beds and the doctors who are looking after these patients, in terms of training our students, we could have a much larger workforce of healthcare professionals who could thereby meet the deficiency that exists as far as the health force is concerned. So better utilization of the private beds for training rather than just patient care is another thing where the private sector can be involved. Second part was regarding data center. I do agree that we need to develop a robust system of data center. We at AIIMS have been trying to do that. We have started a whole AIIMS registry as far as data is concerned. And what we have done is we have what we are called a CRU, a clinical research unit. And this is something I feel all hospitals and training institutes should start, because this research unit helps the clinicians to do good quality research and answer questions while they are actually doing their clinical work also. So the CRU that we have at AIIMS is actually now actively involved in trying to help in data collection. And we're also looking at it not only from the data, but even from developing a biobank. So for taking blood samples and storing them. And now when we are having patients who die, we take the consent and do a limited biopsies of various organs. And therefore a tissue bank is also created. So that if down the line, 3 months, 6 months down the line, a researcher needs to really answer a question and he needs these samples, they are available there for research. You could be looking at research at a genomic level, a proteomic level. And that is something that we need to do at a larger scale. So when you're talking of data, it's so not only data which is the patient's data, but even other data which is available. And there is a lot of collaboration that AIIMS is doing with IIT, Delhi IIT, Kharagpur, where we're looking at various models like artificial intelligence, which could actually help in terms of prediction models as far as the outbreak is concerned. There's been one question which I'll just take finally, which is basically on the question and answer, this thing where that COVID is now beyond the lungs and it is basically a vascular disease, and should we look at increased capital investment? I do agree that there is a need. that we start looking at COVID in a holistic manner, whether it be managing patients who have strokes, who have cardiac events, or even who need dialysis. So we're not looking at only ventilatory support, we're looking at dialysis machines, we're looking at CT scanners, and a holistic approach is required when you're looking at managing these patients. Is it an airborne disease? This is something which is a big debate going on between WHO and a large number of scientists. I do believe to some extent COVID can be airborne, but the degree of infection that is transmitted through the airborne route is something that is debatable. The airborne particles or aerosols do stay indoor for a longer period of time. And if the ventilation is poor, it can have a potential of causing infection. And therefore, in an indoor environment, cross ventilation would be something that would be really advisable. Thank you.
Thank you, Dr. Guleria. KP Krishnanji, would you want to also respond to some of the issues which were raised?
No, Rajesh, really nothing specifically addressed to me. I think Ajay has dealt with all of them. Thanks.
Rajesh, before we end, could we just, I know that there was a hand up from Subhamoy Bhattacharjee of the Business Standard who was with us. Subhamoy, do you still have your question?
Well, I just wanted to say that every year the health department of both the central government as well as in the states return a lot of funds. So I would suspect on the Ajay's question of building up regulatory capacity, I would agree there. And I think that is where the problem is, not in terms of allocating more money. I think even if more money was suddenly provided to these departments, they wouldn't be able to absorb it and we would have misallocation.
Rajesh, back to you.
Okay, so let me summarize by saying that the twin aspects of public health as well as curative health and the various challenges and problems related to these two aspects, which have been highlighted because of the pandemic that we are facing, have been nicely summarized by Ajay Shah, and then in the subsequent discussion, let me take this opportunity to place on record our thanks to Ajay, to KP Krishnanji, to Dr. Randeep Guleria, to Karthik, Rohini, Pankaj, Raghu, and Shubhamoy. I think I have not missed anyone. In case I have, my apologies. So again, many thanks to all of you for joining. Thank you.
And thank you, Rajesh, for chairing this so expertly. This brings us to the close of the second day of the India Policy Forum. I know we are running a little late. We are 16 minutes behind schedule, but I think the discussion we've had and Ajay's truly seminal paper, which I think Karthik framed as, application of first principles to an area and a subject that would benefit greatly from the kind of thinking that we economists do on public economics. So I think it's been a very rich discussion. Thank you, Rajesh. Thank you, Ajay, for the paper, Dr. KP Krishnan, Dr. Randeep Guleria, and all the participants who've been listening in. There are a number of questions. Randeep took one, but there are a number of other questions also in the Q&A box, and we will share them with Ajay Shah and the discussants and urge them to please respond to you. Your emails are associated with your questions, so we will get back to you. Again, I think this has been a very fruitful day. Tomorrow is the third day of the IPF. We will be talking about a roundtable discussion, which will also include Abhijit Banerjee and others, including the Expenditure Secretary in Ministry of Finance, TV Somanathan, on safety nets and how the pandemic is giving us lessons for how India should be shaping its safety nets and its social protection. And then we have a paper which is jumping to the other side on inflation targeting and what has been India's record, a superb paper by Barry Eichengreen of Berkeley and Poonam Gupta and Rishabh Chaudhary at the World Bank. So I invite you all to join tomorrow at 6:30 p.m. We are grateful to our friends in California who have woken up very early at 6 a.m. to be with us. We thank you for that. And again, It's a great pleasure to be here. I want to thank our sponsors, the National Stock Exchange, SBI, as well as Reliance Industries that have made some of this possible. We're grateful to them. And again, I'm grateful to all of you for joining us. Thank you and good night.